All right. Hi, everybody. Welcome to our American Hernia Society first webinar of the year. Today, we're going to be talking about some high yield cases and I'd like to introduce the examiners. I'm Alice Race. I'm attending at West Virginia University, and our examiners are Dr. Chang from Inspira Health, Dr. Shmola from Stony Brook University, Dr. Takla, who's at Wentworth Health Partners at Seacoast General Surgery, and Dr. Hodgins at Prisma Health. Our examinees are Dr. Reed, who's a MIS fellow at Prisma Health currently, Dr. Magallanes. Did I pronounce that right? Is that terrible?
No, it's very close. It's Magallanes.
Magallanes at Ohio State. Dr. Liu, University of British Columbia. She's a PGY4, and then Dr. Sharon, who's PGY4 at Penn Medicine. I'm going to pass it over to Ben to give us a little plug about Hernia Society.
Hi, everyone. My name is Ben Fung. I'm one of the two co-chairs of the AHS Residents and Fellows Committee alongside our fearless leader, Katie Schlosser. Just wanted to again welcome you all to the first of many of our AHS webinars organized by the Residents and Fellows Committee. Whether you're tuning in right now or going to be watching the video recording afterwards, we're excited to have you. Just a quick note, our committee is really responsible for organizing as many events as possible to promote interest in hernias and in AHS. This is everything from our quarterly newsletter, where we're featuring some of our favorite videos and recent articles, webinars like this, as well as social events and networking events at the AHS conference every year. So I think if you're watching this video, if you're here today, you probably have an interest in hernia. All of us on this panel and all of this committee would not be where we are today without our connections, relationships, our mentorships that we built through the AHS. So if you're interested, sign up for a newsletter. We'll have a link in our chat. Join the AHS if you haven't already and discover the wealth of information and relationships that you'll discover there, and sit back and enjoy the show.
Awesome, thanks, Ben. So as a reminder for the examiners and the examinees, you'll have 7 minutes per scenario. I'll keep the time. At the end of the 7 minutes, you'll have an additional 7 minutes for feedback from either your examiner or the crowd. And if you guys are ready, we'll get started. First examiner is Dr. Chang, who will be examining Dr. Reed.
Good evening, Dr. Reed. How are you doing?
Doing okay.
All right, you ready for a case?
Reckon.
Okay, so Dr. Reed, you're the fellow on call, and you get a call from the emergency department saying, well, we have a fellow down, or actually a lady down here. She's 50 years old. She is morbidly obese. She has a BMI of 65. And she came in with the complaints of a painful umbilical mass. Now, she hasn't had any prior surgery, but she does have a pretty significant past medical history. She does have pretty poorly controlled diabetes mellitus. She has COPD, and she's actually been on several courses of steroids over the past year by her pulmonologist. And despite that, she continues to smoke. This is, the photo shows your physical exam. So, yes. So what are you suspecting?
I mean, that looks like an incarcerated hernia to me. So you've given me a pretty good history already, but I would look through her chart before coming down, see if she's had any prior surgeries in our system. Before I go down, I'd make sure that the ED has labs cooking, including a CBC, BMP, LFTs, and probably a BBG with a lactate. I'd make sure they send a type and screen, and that they have two large bore IVs in place. I'd go see the patient. I'd ask her, you've given me a pretty good medical history. I'd be interested to know if she's still on steroids currently, and I'd ask her about prior surgeries, and you mentioned that she's a smoker. I'd ask about alcohol use, on my exam, I'd be wanting to know, like, is that tender? Is it firm? Can I reduce it? Does she have peritonitis? What's the abdominal exam generally?
Okay, so in response to some of your questions, she confirms that she has not had any prior surgery within the hospital system or anywhere else. She does continue to smoke 1 pack of cigarettes a day, and she says she's a very occasional social drinker. She takes a glass of wine maybe once or twice a week. Now, in terms of the IV access, the ER received your orders and they put in 2 large bore IVs, and they did check labs. Her electrolytes were all within normal limits. She does have a mild leukocytosis. Her white count is 14.2, and her lactate level is only mildly elevated at 2.0. Now, so you go down and see her, and you try to reduce the hernia, and you're unable to do so.
Okay. Do we have a set of vitals?
Yes. So she is afebrile, a little bit tachycardic, around a heart rate of around 110. She is normotensive. Her blood pressure is 110 over 65, and her respirations are 16. And she is standing at 97% on room air.
Okay.
Dr. Chang, and plus your audio.
Oh, can you hear me now?
Okay. Yep. Can definitely hear you. So I would, contact the ED and probably have the ED provider there, and I'd have them give her some IV sedation and analgesia, and try to reduce it with some sedation and analgesia. Okay,
so she'll receive some IV Versed, and also IV Dilaudid, and even after multiple attempts, you're still unable to reduce the hernia.
Okay, and is she having obstructive symptoms?
That she is not. She denies, having any vomiting. She was able to have flatus and a bowel movement earlier. She is mildly nauseous, but she thinks that might have been due to the pain.
Well, it sounds like this is a painful, tender and incarcerated hernia, and I'm certainly worried for strangulation. So that would merit repair. So I would take the patient to the operating room for a laparotomy with ventral hernia repair.
So prior to taking her to the operating room, would you get any imaging studies?
Yeah, while the OR is spinning up, I would make sure that she has an active type and screen. I'd get an INR, a chest X-ray, and an EKG, just for pre-op risk stratification and a baseline. And I'd get a CT of the abdomen and pelvis with oral and IV contrast.
Okay. And Dr. Race, do we have a CT?
So yeah, that I'm seeing some axial cuts of a CT of the abdomen pelvis with IV contrast, and it does appear to show an incarcerated umbilical hernia containing some small bowel.
Okay. So what is your plan next?
Given how tender this is and the tachycardia and elevated lactate, this wouldn't change my plan. I would still plan, given that I couldn't reduce it at bedside, I would still plan for operative reduction and repair.
Okay, so you take this patient to the operating room. Can you tell me what your approach would be?
So I'd position the patient supine, make sure that thrombos are on and functioning. I'd make sure the patient has preoperative antibiotics, and I'd conduct a JACO-approved timeout to verify the patient procedure. I would conduct a midline laparotomy. I would reduce the hernia, And I would primarily close the fascia with a #1 stratus fix suture and ovicual internal retention sutures.
Okay. Now, would you consider using any mesh?
No, no, I would not. I would make sure that I run the entirety of the small bowel and thoroughly inspect the small bowel and make sure there's no ischemia, bruising, and no bowel that needs to come out. But for this patient, I would primarily repair her hernia, and then I would see her, serially in the office. And when it comes back, which I think it almost certainly will, then we can work on rehabilitation and repair.
Okay, so let's move forward in the interest of time. So several months later, she does come to your office, and she now has a hernia recurrence. Now, this time, the hernia is reducible, but it is starting to bother her. So what would your rehabilitation consist of?
So how old is this patient again?
She's 50.
So she's 50. So, there's a lot of things I'm thinking about. She's got a lot of medical comorbidities. So for her diabetes, I'd want to make sure that we get an A1C, and I'd make sure that she's following with family medicine or endocrinology or someone to make sure that's well managed. For her COPD, she's gotten several courses of steroids. I would want to make sure that I'm not operating on her, obviously, when she's on a course of steroids, and I'd send her to a pulmonologist for perioperative risk stratification and optimization. She's 50 years old, so she's due for a colonoscopy if she hasn't had one yet. So I'd inquire about that, make sure that she has a current colonoscopy. She's overweight, so I refer her to a weight management institute for consideration of medical versus surgical weight loss. And then finally, I would refer her to a smoking cessation plan.
Okay, so
That's time.
Mm-hmm. Okay. So what would be an acceptable hemoglobin A1C for you?
I think less than 6.
Okay, that's a pretty stringent requirement. I think most people, kind of aim for a range of 7 to 8% for the hemoglobin A1C. So I think you did an excellent job, Dr. Reed. I would agree that the patient needed operative intervention when she first presented to the emergency department. We don't really have a choice given the amount of pain that she's in. And I agree, I would not use mesh either. But, definitely some rehabilitation, when she does have a hernia recurrence, which again includes weight reduction, control of her diabetes, management of her steroids, and control of her COPD, and smoking cessation as well. Are there any other feedback or comments from the audience?
I got 2. First, I want to ask Dr. Reed, have you already passed your boards? Are you still in the works?
I'm waiting on the scores, so who knows?
So presumably we have already passed your boards. I hope that's entirely behind you. So thank you for participating. Second part is a curveball that I have seen is, what would you do if you could not close fascia on this patient?
If I couldn't close fascia on this patient, what I note on the CT, it only looks like a 5 centimeter defect. So hopefully I can get her closed primarily. I did use internal retention sutures, because I feared there might be some tension. But if I couldn't get her closed primarily, I would probably raise lipocutaneous flaps and perform a bridging. Actually, no. If I can't get the fascia closed, then I would do an underlay vicryl mesh, and I'd raise lipocutaneous flaps and close that over the mesh.
Gotcha. And I think that if you had a good plan for all of those, so a underlay vicryl mesh, that's going to come back. Doing a bridging vicryl or absorbable mesh repair, that's going to come back. I think if you have a justification for all of those, that may be an appropriate response. I think we're very much in flux in terms of what's coming across the boards in this particular type of emergent case. So that's only my only 2 cents.
I think it's reasonable in the case, let's say, if the defect is more than 5-6 centimeters, you cannot really close it. The you know, I personally would put a piece of Phasix ST as a bridge just to reload the recti. It will stay around for 18 months. You know, it's still not a bad bailout option. Retention sutures really don't work very well, as far as I remember. So that's just my 2 cents. Phasix.
I would also use Phasix ST if I couldn't get it totally closed. All right, there's no other comments, additional comments. Great job, Dr. Reed. Looks like they're training you well in your fellowship. Let's move on to the next case. And this will be Dr. Shmulov and Dr. I'm sorry,
Dr. Magallanes, bring it up.
Magallanes.
All right, good evening. So you're a surgeon on call in a small community hospital, and they call you for 67 years old, tiny woman who is coming here with acute onset of right groin pain. She also doesn't feel very well for a couple of days now. She has some subjective fevers. Her medical history is significant really only for AFib, for which she is taking Eliquis, and her last dose was today. Otherwise, she additionally is a daily half a pack smoker, and the rest of your history is unremarkable. She has no prior surgical history.
Okay. I would start by going down to see the patient, again, a focused physical and history exam, focusing on any prior abdominal surgeries, whether this has ever occurred before, whether it's been reduced or whether it's just a new bolus that she's noticed, how long she's been using tobacco, if she has any lung disease associated with that, if she has any other medical conditions. If from a social history, I want to make sure she does not use alcohol in excess. That would raise concern for liver disease. And then I would do a focus exam, getting vital signs, and then examining her groins, bilateral groins, but also her abdomen for any scars.
All right, so she looks okay. She is not toxic appearing. Her vital signs are unremarkable and normal. She's not tachycardic. She is currently afebrile. Her past surgical history is non-existent except for some tonsillectomy in the past. Medical history, as discussed, just AFib on Eliquis, and then she's a daily smoker, but she doesn't use alcohol. On exam, she has no abdominal distension. She has focal tenderness in right groin area with some minor skin erythema. You feel a palpable bulge, which is tender. Otherwise, her exam is non-peritonitic, and she, really nothing actionable.
Okay, and not reducible.
It's not reducible. It's pretty tender.
Alrighty. I would start by making sure she has 2 large bore IVs and start with getting full set of labs, including lactate, CBC, coagulation, and chemistry panels. If she's stable enough to undergo a CAT scan, I'll also get a CT scan to see if there's any bowel incarcerate or if it's just fat containing to help determine my approach.
All right, well, you start her on some maintenance fluids, you gave her some antibiotics. Lab work came back as leukocytosis of 15 with neutrophilic predominance. Otherwise, labs are non-actionable. She has normal lactate, no AKI. She has slight elevation of APTT, but remember, she's on Eliquis. So you go ahead and do your CT scan with AV and PO contrast, which we'll show you in a second.
Okay, I see no bowel dilation. I don't see any portal venous gas. Can we scroll back up to the hernia? I saw I want to say it's fat containing, but I want to make sure it's not edematous bowel wall that I saw.
And then also, I think on the next slide, we will have the sagittal view. That would be also helpful after we review this one.
Okay, I don't see any bowel in that image.
So pay close attention to the left still image.
Maybe maybe a knuckle of bowel with some mesentery that is going through there. Alrighty, so I'm worried that there's incarcerated hernia here, and I want to offer operative repair. I will talk to pharmacy to see if there's any reversal agents for the DOAC that she's on.
Okay, well, pharmacy sends you a dose of Anexanet Alpha, and she agrees to get it.
Okay, good. So now that she's reversed and undergoing resuscitation, I'll take her to the operating room for a laparoscopic tap in order to reduce this defect and repair.
Okay, so you get access, you do diagnostic laparoscopy, and you see that the base of cecum is really against the abdominal wall, against the groin region, and then you think that it looks like an appendix sneaking into the hernia.
Okay, so now I'm seeing a diagnosis of an amirand hernia. So I would reduce the appendix and perform an appendectomy at the same setting, and then proceed with my hernia repair.
Okay, what else? What if you cannot reduce the appendix laparoscopically? You pull on that and it really won't come.
Yep, then I could incise. Is it coming through is it femoral or I could always incise the hernia defect to reduce the appendix.
All right, let's say you are able to divide. So you first of all, you know, during laparoscopic exploration, you notice that that's actually a femoral hernia, and you're not really able still to reduce it.
Okay. If I'm still able to reduce it laparoscopically, and I'm worried about what may occur, then I would desufflate and make a groin incision to prepare to open the femoral space through an anterior approach. I'm still aiming to perform my appendectomy either laparoscopically or through the groin with plans to perform a McVeigh repair.
Okay, very good. So you're able to reduce the appendix. You complete your laparoscopic appendectomy without any incidents. Can you describe me how would you do McVeigh?
Yep, so anterior approach, go down through the layers, opening the external oblique, making sure to protect the ilioinguinal nerves, genitofemoral nerves, and the epigastric nerves. Once I am at the inguinal floor, I will the main goal is to join the conjoint tendon with the inguinal ligament, I believe, and to do that
Cooper's.
to do that primarily.
All right, very good. So, you know, let's say you did McVeigh, everything is fine. We don't have really any time left for post-op complications. But the one question I have for you, if your appendix really looks pretty gangrenous and inflamed, will you still consider any mesh placement?
No, not if it's gangrenous and inflamed. I would not consider mesh.
What if it's just early serositis and appendix otherwise looks fine? Are you able to do lap IB, you know, in a clean fashion?
I think a clean contaminated case, I'll consider mesh placement. Yes.
All right. All right. Well, I guess we're on. Yep. So, you know, just my kind of comments on that. I think you did a very good job with working the patient up and making sure you do reversal of your DOAC. You know, I ask you specifically to look at this sagittal view because you actually see, unfortunately, picture is not very large, but you see that the content is going underneath the inguinal ligament, and then also, obviously, on your laparoscopy, you are able to see that this is a femoral hernia. So I'm not exactly sure if on the boards I would do, you know, in the case, if it's a clean contaminated case, you know, you may be criticized for doing a mesh repair even in the TAPP space. You know, I'm not exactly sure how I would answer this question. I know I did some literature review, and then it looks like folks you know, would do that in some case reports. But you know, other than that, you definitely want to do McVeigh, and if you know, just come find another day and do a nice top repair for this patient, I think. And that's just one more thing is that the ambiant hernia is again just a little bit of medical trivia. This is the appendix in inguinal hernia, right? This is the gangrenal hernia. I mean, anyway. Okay.
Yeah, and I think
Artem, my two cents is I think there's decent data to support mesh repair even in contaminated cases of inguinal hernias. I think selection of mesh, you know, is either going to be a macroporous polypropylene or some sort of absorbable mesh. And again, it kind of comes down to you got to have a reason for picking what you do and be fairly confident with it, because you're going to have people entirely across the spectrum. You know, even amongst my partners, there's people who would not put any mesh, would put phasics mesh, or would put non-absorbable mesh. And so I think that we really sort of have to have a reason for choosing what we're doing. But even in gangrenous cases, there's some decent case reports of, or case series, I guess, of what to do, because otherwise you're stuck doing a tissue repair. And many people have very poor experience with that.
Yeah, I agree with you totally. There was actually a discussion IHC recently, and folks were mentioning that, you know, how Andreas Koch will do, you know, reinforced shoulder ice with phasics, and that's all really sounds very interesting. But, you know, on boards, I guess the safest is to play the safe game, and, you know, then definitely, I guarantee you, if you're going to put the mesh with this appendix, I mean, that doesn't look too bad, but, you know, the patient will come with infected mesh, and now, you know, you screwed yourself. So, I don't know.
Yeah, I think I just have a couple of advice. You did a great job. I think one thing is, you know, when you answered the what would you do, you said a laparoscopic tap. So I would kind of hold your horses a little bit. So when you're in a board situation, you say, okay, diagnostic laparoscopy, and then they'll tell you what they're seeing. The second thing, like Katie and Artemis said, you know, if you were going to say something that's not super classic, a lot of the examiners are old school examiners. Some of them are not, some of them are newer. So it really depends on who's giving you the exam. So you have to be a little bit smart when you do that. But then when you see a sort of an old school examiner that you know they're old school, you might want to go very classic. Now, if you're going to do something that's, you know, put a mesh in such a situation, which some of us do, I've done this before, and you're going to defend it with some sort of an article or data, you better know every single line of that article, because if you're going to say, oh, well, this happened, then you're going to get into that argument. So you got to pick and choose your battles. So if you feel that, you know, you're confident that you have this information, it's in your head, you know everything of it about it, then do it, say it, and then just say, this is what I'm going to do, and move on. I mean, there's always going to be complications that they're going to get you into, so that because they want to see where you're going to stop, because all of us in these exams have to stop somewhere. So,
Sure. Thank you all.
great job.
I got away with putting mesh in this laptop. The other thing, Max, I just wanted to mention is that when Dr. Shmulov asked you how you would reduce, if you couldn't reduce a hernia, where would you make your incision to open up the, like, where would you cut? That's a very common question that you're asked, right?
Yeah. From the anterior approach, I keep thinking
Either way, anterior or laparoscopic.
yeah. I'm not too sure. My mind keeps going back to operator for some reason, so I'm kind of hooked on that, but I know that's not the right answer.
So the
Think
medial
about-
border, yeah. Think
Hmm.
about where your anatomy is, right? The medial border of your femoral hernia is your femoral vein,
Mhm.
right? So you just don't want to incise medially. Generally, we say laterally.
Okay. Besides
All
lateral.
right. Great job. All right. Dr. Takla is next, and Dr. Liu is our next.
All right. All right, welcome, Dr. Liu. So our next case is a 45-year-old female who one of your esteemed partners who was on call did about 4 days ago did an open sigmoid colectomy for diverticulitis and did a washout and was able to actually do a primary anastomosis. And you're on call on the weekend. It's Saturday night, and then you get a call from the floor saying the patient's complaining of, you know, pain and a painful mass in the midline. So how do you proceed with that?
So I think I first would go assess the patient to get an understanding of what this mass might be. I think my differential right now remains quite broad, being you know, a seroma or a hematoma. I'd also ask the nurse to please get an up-to-date set of blood work, CBC, BUN, creatinine lights, INR, PTT, group and screen, and a set of fresh vitals as well.
All right, so the nurse calls you back and says the patient is a little bit tachycardic, 120. She's had a low-grade temperature earlier in the day, 38.4. She's had a few episodes of vomiting earlier in the day. She feels like she's distended, and she hasn't had bowel function since her surgery yet. And then she also told you that the patient told her earlier when she went to the bathroom, there was a gush of fluid that came out of the staples. And then this mess is really bothering her. she puts in that she draws the labs that you asked for, and she's asking you what to do now.
So I would explain to her that I'm worried about a fascial dehiscence, especially in the context of this gush of fluid and this postoperative ileus. I would get an urgent CT abdo with PO and IV contrast and speak to radiology to make sure it gets done very soon. And hopefully I've assessed the patient as well.
All right, so you go and see the patient. She's very distended. She's vomiting. She's tachycardic. And then the radiology has a stroke CT scan that they have to do first. So what do you do from there?
Okay, so I would explain to the nurse and to the patient that it would not be appropriate for the patient to go down to CT right now because there is a delay. But in the context of this fascial dehiscence, the patient will need to go back to the operating room emergently to explore the wound. So I'd consent the patient for an exploratory laparotomy, possible closure, possible bowel resection after the risks and benefits are discussed.
Is there anything on your exam that you would be looking for before you do that, or any other things that you would want to do before going back to the OR?
I would want to understand whether this is a partial fascial dehiscence versus a full. Also, if there's signs of evisceration, if there's clearly bowel contents coming out, I would cover with a moist gauze and an abdominal binder on the way to the operating room to prevent any evisceration on transport.
So you look through the skin staples, and you actually see small intestine that's very distended through there, and also some omentum in the upper portion of the incision. Do you want to do anything else before you put the patient to sleep?
I would place an
Besides the
NG tube to
Okay.
prevent the risk of aspiration on induction.
All right, so walk us through what you're going to do from there. After you put the NG tube, puts a lot of bilious fluid out, they put anesthesia, put the patient to sleep. They're doing okay. Now their heart rates are still in the hundreds, and you're in the operating room. Tell us what you would do.
So after the patient's positioned, prepped, and draped in the usual sterile fashion, I would then proceed with opening up the incision. I'd explore the wound to see where the dehiscence is coming from, and see if the area of small bowel that I saw on my examination has any signs of ischemia. If so, then I may need to perform a bowel resection, but based on my understanding, this is quite acute, so I'm not suspecting that I'll have to do that. And then I would also explore the area of the previous anastomosis and see if I can bring the fascia back together.
All right, so you kind of, run the bowel, you look at the anastomosis, there's no abscess, there's no leak. The bowel is just very, very dilated. You're sort of asking anesthesia to put the NG tube on suction. And so how do you close the abdomen? Do you leave it open? Do you bridge it with a mesh? Like, what would be your approach, and how do you assess for, all of these options?
So I'd ask the anesthesiologist how sick our patient is. If the patient is doing very unwell and may require an ICU stay, then we could leave the patient with an open abdomen, temporary abdominal closure with negative pressure application, and maybe diurese the patient as well. That might help us to bring the fascia back together. Ideally, I'd like to be able to perform a primary closure, bring the fascia back together in the skin. But if not, then I may have to perform a bridging vicryl or bridging repair and live to fight another day.
So let's say the patient stabilizes, and then the anesthesia is able to get a lot of the liquid out through the NG tube, and you feel you can close it primarily. How do you close it primarily? What suture you use? What length of suture do you use? And tell me about your technique of how do you close this.
So I would apply the results of the stitch trial, so 1 centimeter by 1 centimeter stitches with a slowly absorbable suture that is 4 times greater than the length of the incision. And so usually I used a 1 or O-loop PDS suture, run that across. And I would actually, I don't know if this is very evidence-based, but I would place retention sutures in this case, O-vicryl figure of 8 sutures every few centimeters.
So internal retention sutures.
Yeah.
Okay. All right. I think that's all I have. You did a great job.
Okay.
I think overall it went well. I think you asked, the right questions. There's not a whole lot in the sort of the main stem of the scenario, but like you said, in any patient, you go assess them, ask for the right things. One prompt is obviously anybody that has a sort of an ileus or bowel obstruction that you're putting to sleep, an NG tube will help prevent aspiration. You sort of knew some of the options there, or I gave you some of the options what to use for this. One other thing that sometimes comes up in these cases when you're closing, they'll ask you, well, what do you ask anesthesia about, like peak pressures or the patient developing abdominal compartment syndrome? Sometimes post-operatively they may ask you about that too after you close. But I think overall you did a good job.
Thank you.
So a little bit of feedback. I think you realize along the way that you know, a lot of times with these evisceration cases, typically on physical examination, you will see the evisceration. So oftentimes I don't even ask for a CT scan, and you know, so you want to just examine the patient first. And then the second point is I wanted you to familiarize yourself with the what's reported in the stitch trial. So the stitch that they use in that trial is actually the 2O PDS on the SH needle. And they're describing a 5 millimeter bite and then advancing by 5 millimeters. The most important thing is, you know, there's a 4:1 suture to wound length ratio.
Oh, thank you. Thank you. It's 5 millimeters.
Which is excruciatingly slow if you have an inpatient attending.
I think Leif Israelsson, who did the trial on, he was originator of this stitch. In his clinic, they boast 0.3% rate of incisional hernia, and the nurse measures the length of the thread and the length of the wound, obviously. And if it's less than 4:1, I think the ratio is, the only instrument you allowed is scissors to cut your suture and do it again.
That sounds like torture.
All right. And then our next case is with Dr. Hodgins and Dr. Sharon. It's the slide.
Okay. So you got a 35-year-old female with a BMI of 29 and a history of GERD. She's presenting with nausea, vomiting, and chest pain, and a history of a laparoscopic cholecystectomy. You're seeing this patient in clinic.
So I would get a full history, ask how long this nausea, vomiting, and chest pain has been going on for her, if it's something acute or something that has been intermittent for some time. I would also like to know about her GERD, what therapy she's been on for that, how long standing that's been for her, get a set of vitals, do an exam, get a full history.
Okay, so vital signs are normal. She's in clinic. She's got a three-year history of GERD, heartburn, a little bit of regurgitation. She cannot lay flat at night. So she sleeps on a couple pillows. She was trialed on PPI therapy, and this seems to help her symptoms to some degree. And otherwise, she's concerned about the side effects of PPI therapy long term.
Okay. And when did this nausea, vomiting, chest pain start for her?
It's been intermittent for the last 3-4 years. It's been getting steadily worse over the last 6 months.
Okay. And any other notable medical history for her besides the GERD and the lap chole?
No.
Okay. Any issues that she has, like with eating or swallowing, any weight loss, dysphagia?
No weight loss. She notices sometimes she gets a little bit of dysphagia when she eats bread, but that's not her main complaint. It's mostly just the reflux and regurgitation.
Okay. So I would refer her for a barium swallow and also for an EGD. I'm thinking potentially about either a stricture or potentially a paraesophageal hernia. So I'd like to get a barium swallow and an EGD in addition to CBC, BMP, nutrition labs on her.
Okay, all your labs are normal. Barium swallow study shows a sliding 2-centimeter hiatal hernia. On your EGD, you just want to do an EGD on her, or is there anything else you want to do at the same time?
I mean, she's 35. I don't think she potentially needs a colonoscopy. I think there's nothing that I'm thinking of right now while doing the EGD, potentially No, I would just do an EGD.
Okay. So on your EGD, are you doing this or are you having your gastroenterologist
I
do
would have
it?
my GI colleagues do the EGD.
Okay, so they do an EGD and they report back that she has a paraesophageal hernia. They do not note any mucosal changes to the esophagus. They don't see any ulceration of the stomach. Other than that, just a notable for the hernia.
Okay. And another thing I would want to get for her, it would be esophageal manometry to make sure to assess the function of her esophagus.
Okay, she's sent for manometry and she has a hard time getting the catheter down and they abort the procedure.
Okay. I would see her back in clinic at this time and talk to her about a laparoscopic paraesophageal hernia repair with likely a fundoplication to treat the symptoms of the paraesophageal hernia and her reflux as well.
Okay, what are you going to tell her about expectations postoperatively as well as limitations postoperatively?
I would tell her I would expect her to be in the hospital overnight. I would plan to do this laparoscopically, minimally invasively. Depending on how large the hernia is, I would likely plan to not use mesh and repair this primarily, but tell her there is a possibility of mesh. I would say that she would be on clear liquids on day 0 and standing antiemetics while she's in the hospital to prevent retching. And that she would likely go home on day 1 on a full liquid diet that she would be on at home for a period of about a week or so. And then we would follow up and see how she's doing and then slowly advance her to softs from there. But that she should expect in the post-op period to be on standing antiemetics, whether she's nauseated or not, to prevent retching around the wrap. I would say that she would be on PPI at least in the short post-op period and full liquids for some time.
Okay. She asks you, do I need to have this done now? My symptoms are relatively well managed on PPI therapy. I might be getting pregnant in the next couple of years. Is this something that I should be considering?
I would say this is not something which should affect her ability to get pregnant. She had previously mentioned that she's, having issues sleeping at night and that she's sleeping upright and that she was concerned about long-term PPI therapy. And that I believe that this would help her with her symptoms, and I would suggest that she do it now.
Okay. So she consents and you're in the operating room. So walk me through your case.
So I would make sure that she has both arms out in a web roll. I would have her on a footboard because I would expect her to be in reverse Trendelenburg for some time, and I would make sure my anesthesia colleagues know that. I would have them place an OG tube initially. I would do the procedure laparoscopically, start by entering pars flaccida, trying to bring down the hernia sac out of the hernia, making sure I have at least 2 centimeters of mobility of the intra-abdominal esophagus. And then I would plan to do a 360 Nissen wrap over a bougie placed by our anesthesia colleagues.
Okay. During your dissection, you come across a paired vessel within the pars flaccida. What are you going to do about that?
So at this point, I would expect that she has some aberrant anatomy, possibly a replaced right. So I would be careful to not dissect that vessel and leave it intact.
Okay. As you're doing your mediastinal dissection, you feel like the stomach just isn't coming all the way down into the abdomen like you want it to. What can you do during the surgery to ensure that you're actually getting intra-abdominal esophagus?
So if I'm having issue mobilizing the esophagus into the abdomen, I can do a collis gastroplasty and staple off part of the stomach to create more intra-abdominal length.
How are you going to know where the GE junction is?
So I can't even get the GE junction down.
Well,
so
what tools can you use in the operating room?
I could also do an on-table scope to see where I can find myself intraluminally and see where, looking at the screen from the laparoscopy, seeing where I am with my scope at the GE junction and in the OR.
Okay, so you do your scope and your GE junction is indeed 2 to 3 centimeters below the hiatus. So you go ahead and close the crura. You mentioned you're going to do a Nissen on her.
I would plan to do a Nissen on her, yes, because of her reflux.
Okay.
As long as I have adequate fundus.
Okay, you do and you do. So you wrap up the case and she's recovering postoperatively. You see her back in clinic after a couple weeks. She's doing great. any recommendations going forward for her, kind of diet advancement, physical limitations?
So at this point, it's been a couple weeks. I would expect that she had been on full liquids at some time. I would just have her start with some soft foods, but then I would expect in the next couple weeks she could advance. I did this laparoscopically. I would say that she can kind of go back to her normal activities as tolerated, and I wouldn't recommend any specific like long-term follow-up or need for any other imaging unless she were to become symptomatic again.
Okay. She comes back a year later and her reflux is gone. She's very happy about that, but she's starting to have a little bit of an issue getting liquids and some solids down.
So at this point, it would be somewhat of a late time for the wrap to, if the wrap were too tight, I would have expected to see that in the early postoperative period, and I would have done this over a bougie. But I would get a barium swallow to start.
Okay. Barium swallow shows narrowing at the GE junction, kind of as expected for a fundoplication. Looks like everything is still below the diaphragm, but there is a little bit of upstream dilation of the esophagus and some tertiary contractions of the esophagus.
Okay. I would ask my GI colleagues to do an EGD and balloon dilation.
Okay, they do an EGD. Wrap looks pretty good. No evidence of Barrett's or esophagitis. They dilate her and she feels better for about a month, but she still comes back and she's not feeling great. Still having dysphagia.
Okay. So then I think I would probably have to undo talk to her about potentially taking down the Nissen and converting her to like a toupee or a fundoplication, a different type of wrap that isn't 360. I would say that she's probably not doing that. This is going to continue to be a problem for her unless I address this.
Okay. How much time do we have?
That is time.
Okay, good. I thought we were gonna be about done. Okay, so I thought you did really well. I threw a lot of curveballs at you. Foregut patients are always tough. This is just a typical GERD patient, but these are the problems you run into during the workup.
Yeah.
Like you can't do manometry, so what
Sure.
do you do? In general, and I think this is becoming more standard, is an esophagram works, but if you do some sort of bolus esophagram, whether it's a bagel or a marshmallow, you can get a better idea of esophageal motility. So
Okay.
I would hesitate to wrap to do a Nissen on some.
Do a Nissen without the full esophageal motility.
Correct.
Okay.
You need some assessment of motility. So if I push you back and say she didn't tolerate manometry, well, you can still endoscopically place manometry. You could
Okay.
potentially on your boards bring up EndoFlip. I probably wouldn't just because it's still new enough. But I would still push for getting a formal manometry done if there's any question of motility. Because when you wrap somebody with poor motility, you'll get this and then you got to take it down.
Right. And that's why I wanted the manometry, but then I didn't know the alternatives for when that was not available. So then in the OR, I probably should not have done a full Nissen, but it's good to know that there are other.
Correct. And I would say, again, I'm biased because I just do foregut surgery, but I think most people would err on the side of a partial fundo if there is any chest pain or dysphagia reported. Otherwise, I think you worked her up appropriately, you got through the case appropriately. I always scope everybody intraoperatively. It does not hurt you. It can only help you. You can truly see where your GE junction is. You can evaluate the wrap that you do. So don't be afraid to do an EGD on the table on every single one of these patients. Like there's no way it does any harm. Any other feedback or questions? Yeah, no, I thought you did a good job. You came back rapid fire to all those things. That was good.
Yeah, she flew through that. Dr. Hodgins, that made me sweat. I was having flashbacks of you.
No, I agree. And then also, I mean, I guess some other questions that might come up, and I agree. I mean, most of us now do more toupees than Nissens, unless we have a good sense of the motility. But I think also one thing that might come up, because you mentioned mesh and no mesh, and that discussion might come up. Does it, what type of mesh would you use? And that sort of thing, and when you would use it, and does it affect the recurrences and that sort of thing? So
sure.
Good job.
From what I know, that the most recent data that I saw, the randomized controlled trial, it did not, doing the repair with mesh did not have any difference on the recurrence versus primarily repair.
Yeah, the mesh is short-term recurrence. I think this, absorbable mesh can still have some benefit, but long-term, yeah, it all sucks and it all ends up being a high recurrence rate.
All right, you have time for one more, or what do you guys think?
Let's do it if we have a willing participant.
We have a willing victim. Dr. Reed, going to be examined by Dr. Chang again. And then this, I apologize, we don't have a prompt, we just have a CT scan.
Hello, Dr. Reed. So you're the fellow on call in the ER again, and this time they call you with a 52-year-old female. Now, she did have a colostomy performed for perforated diverticulitis about 2 years ago. And she now comes in with a 1-day history of nausea, vomiting, as well as pain at the site of the colostomy and also decreased stool output from the colostomy. She's pretty healthy otherwise. She just takes some medications for hypertension and hyperlipidemia.
Okay, so before I go down, I'd look through her old operative reports and make sure I'm familiar with what was done. I'd go see and evaluate her. It sounds like we have, from the slides, an acute incarcerated peristomal hernia. So I'd make sure we have large bore IV access with IV fluids running. I'd make sure I have a set of vitals. I'd make sure we have a set of labs cooking, including a CBC, BMP, LFTs, an INR type and screen, and a lactate. I'd ask the patient, I'd make sure I know how long it's been going on, any prior episodes of obstruction. I'd want to know, is she still having any gas in the bag, any stool? I would also ask about any other prior surgeries that she's had. And I'd want to know if she's had a colonoscopy since her surgery.
So she has not had any other abdominal surgery, and she has not had any colonoscopies either. And in terms of her acute symptoms, she has no stool, no gas in the bag. And she has been aware that there appears to be more bulging around her stoma over the last few months, but there seems to be increased bulging over the last day or two.
Okay.
Now, on her laboratory studies, she seems a little bit dehydrated on her BMP, but otherwise unremarkable. LFTs are unremarkable. She has leukocytosis with a white cell count of 16 and with a left shift as well. And her hemoglobin is within normal limits.
So I'd perform a full physical exam, including the cardiopulmonary system and an abdominal exam. And I would try to, when I examine her peristomal hernia, I'd try to reduce it at the bedside. If that were unsuccessful, I'd try with some sedation and analgesia to reduce it at the bedside.
Mm-hmm. So on exam, her belly is somewhat distended. And she is very tender with palpation right around the stoma. You definitely feel a firm lump there, which is consistent with an acute incarcerated peristomal hernia. And even after sedation and analgesia, you're not able to reduce the hernia.
So it sounds like this is an acute incarcerated peristomal hernia. And I've been unable to reduce it at the bedside. So at this point, an operative repair, reduction repair would be warranted. So I would make sure that the patient has a type and screen, chest X-ray, EKG. I would call in the OR team and consent the patient for a laparotomy of peristomal hernia repair. And while the OR is warming up, I'd get a CT of the abdomen pelvis with IV contrast. I'm not sure that she'd tolerate the oral contrast. If she's been nauseous and vomiting, I'd probably also place an NG tube and then defer the oral contrast.
Okay, so you got a CT. And describe what you see on the CT.
I think I see a really big colon with air in the colon wall posteriorly, which is concerning for pneumatosis. I mean, I'm not sure which viscus I'm looking at there that's that distended. I'm guessing it's colon, and there certainly is a peristomal hernia. But I mean, she's got a problem, that's for sure. So that definitely warrants a laparotomy.
Okay, so tell me, you have the patient in the operating room. Tell me what you're doing.
So I position the patient supine. I prep and baste with an alcohol-based prep. Make sure I have thromboson and functioning. Make sure the patient has preoperative antibiotics, and I perform a JCAHO approved timeout to verify patient procedure. I would perform a midline laparotomy. I would reduce any volvulus. I mean, I haven't really had an opportunity to really examine the mesentery there, but I'd be concerned about some kind of volvulus. I'd reduce any volvulus, reduce any peristomal hernia. I would decompress the bowel either through the ostomy or by making a small enterotomy and decompressing the bowel, which I would then close in 2 layers as long as the bowel were viable. I would run the small and large bowel from the ligament of Treitz all the way to the stoma. I would resect any non-viable small bowel. And then I would make a determination if I can primarily close that hernia. I would close it with number 1 stratafix symmetric. And then I would go from there.
So you get in there and, initially you find that the cecum was very dilated and kind of dusky in appearance. But once you reduce the hernia and decompress the bowel, still looks a little bit dusky, sort of questionable in its appearance. How would you assess the bowel? Would you resect the bowel at that point?
As long as the bowel is decompressed and it's dusky and not frankly necrotic, I would cover it with a warm towel, proceed with the case, and then inspect the bowel later. If the patient were getting sick, rising lactate, swelling bowel, increased, need for pressors, I would simply place either a Barker type closure and Aphthera dressing. I would not resect bowel, and I would post them for a take back 24 to 48 hours later to inspect the bowel then. But as long as the patient's stable, I'd cover it with a warm towel, give it a little bit of time, and look back.
Mm-hmm. Okay, so would you consider using any mesh in this case?
I mean, I would certainly consider it. If I needed to use some kind of mesh, I would perform a sugar baker repair with like a Vicryl mesh. But for this patient, I think my preference would be a primary closure, primarily close the peristomal hernia. And then I would follow the patient serially. And in 3 to 6 months, if the hernia came back, I would offer them another operation for definitive hernia repair with permanent mesh.
So let's say you do a primary repair with Stratafix, and she's in-house, but even after 4 days in the hospital, she still has no stomal output, and her abdomen is increasingly distended.
So the first thing I would do is, I'd obviously see an evaluation. We evaluate the patient, make sure we have current labs and a current set of vitals. I would inspect, I would palpate the abdomen for cuss. Obviously, it's distended. I would inspect the stoma. I would digitize the stoma and make sure that I can fit my finger below the fascia and make sure that I haven't made my, tightened up the fascia too much. And then, if it digitizes well, and the stoma is pink and viable, you could consider passing a Foley catheter into the stoma to try to decompress it.
Right. So the stoma is viable in appearance, but it does look edematous. And then when you try to pass a finger in, you have a lot of trouble trying to get through the fascia.
So at this point, I'm concerned that that I've obstructed the patient with my fascial closure. I would perform a CT of the abdomen pelvis with IV contrast only to verify my suspicions. And then, if I see kinking at the fascia, which I think that I would, then I would post the patient for a laparotomy. I would undo my prior repair and redo it looser.
Okay. How are we doing on time?
That's time.
Okay, well, again, great job, Dr. Reed. You know, I think that there are several options. You know, obviously the simplest thing would be to try to close down the fascia around the stoma at the time. You know, if there were any questions about, you know, bringing the fascia back together, you know, you can certainly consider a mesh-based appareil, considering that, you know, I am traditional, so considering that there's no ischemic bowel or necrotic bowel involved. Are there any other comments or feedback from the other faculty?
I mean, I think the main thing is to be thoughtful in your operative approach about what bridges you're burning for this patient in the future. Will they ever be able to have their ostomy taken down? Is that even an option for them? If you're considering reciting it, that is a limited territory if this is someone who has a permanent endostomy. And so I think that's really the word of caution for any sort of complex hernia in the emergent setting is what bridges are you burning? And I think you did a good job with that.
All right, I think we have time for one more case, and Dr. Hodgins has volunteered to give another scenario. Are there any examinees that would be willing to do another one?
I'm willing to
Yeah.
learn.
Okay, awesome. Thank you. I will go back to the slides. Similar scenario. You can go anytime. I think you're muted, Dr. Hodgins.
How about now? Okay. So you're on call for general surgery and you're called to the emergency department. They've got a patient, a 75-year-old gentleman who has shown up with nausea, vomiting, and PO intolerance for the last day or two. In the ED, they did a workup on him and obtained an esophagram, which you can see the image here. His vital signs are normal outside of a heart rate of about 110. His labs demonstrate a mild leukocytosis to 12. His potassium is 3.0, but otherwise he has no other abnormalities. So what would you like to do?
I'll start by getting a focus his history and physical exam. Specifically, I want to know if he has a diagnosed hiatal hernia, whether he's ever undergone any hiatal hernia repair in the past, when the symptoms started, how long they've been occurring, if they've been getting worse. I want to see if it's toxic or not. On my exam, I want to see if it's distended, and then make sure his vital signs remain stable. While that's happening, make sure we have large bore IV access. Start resuscitation, and then attempt to place an NG tube for decompression.
Okay, so they get IV access and they give him some fluids. By the time you get down there to see him, his vital signs have normalized now. The NG tube was put down and you got a good 1.5 liters of bilious fluid out of it. He feels quite a bit better. He has a history of hypertension, AFib, which he takes Eliquis for, and hypothyroidism. He did have an open inguinal hernia repair 30 years ago, but has no other surgical history. With regards to his symptoms, he's kind of had GERD for 20, 30 years. He's been well controlled on a PPI. Over time, though, symptoms have changed a little bit to be a little more inclusive of dysphagia and early satiety and a little bit of chest pain.
Okay. Did he recently take his anticoagulation?
Yes, he took it this morning.
Okay. Good thing that we got him decompressed. I'm still worried about him because this looks to be a gastric volvulus. And I would like to proceed with an EGD to look for mucosal ischemia.
Okay. Would you like to do that, or are you going to call GI?
I'm okay doing it.
All right. Walk me through your EGD.
Yep. So I'll put him in a controlled setting. And for this particular individual, most likely in ICU for monitored sedation, if not even in the OR with intubation to prevent aspiration. I would intubate the esophagus, being careful not to over-insufflate as I go down, look for any ischemia in the esophagus, and then go down towards the GE junction. If I can follow the NG tube, that'll be helpful because it would have been decompressed. And then once I'm in the stomach, I'll look for any mucosa changes from patchy ischemia. An attempt to get to the antrum and to the pylorus, but it may be hard in the setting of a recent volvulus.
Okay, so the esophagus is tortuous. There's a little bit of fluid still within that, but you don't see any mucosal changes. In the stomach, there's some Cameron's lesions at the area of the hiatus with a little bit of dark blood in the stomach, but otherwise it does not seem to be ischemic. You are able to get all the way down to pylorus, but you can't intubate the duodenum because the scope is looping in the hernia.
Okay. So now I feel comfortable with that. There's no role for emergent repair of this hiatal hernia. I would bring the patient back to the ICU setting for continued resuscitation and decompression, and then discuss future repair options.
Okay, so it's post-op day or it's post procedure day 2. He still has an NG tube. He's passing gas. He feels better. He's wondering what the plan is.
And I would offer a short-term liquid diet, knowing that this is going to be high risk for recurrence, but at least get them out of the acute setting and plan for a more controlled reduction and fix repair of this hernia.
Okay, so you pull the NG tube out, you give him liquids, and he does well for a day. He's getting ready to discharge the next day, and he starts throwing up again.
Okay, then I think he would fail that, and then we should once again proceed with decompression, resuscitation, and then plan for repair in this admission.
Okay, at this point, he's been off his Eliquis for a little bit. His labs are normal. He is hemodynamically stable. So he agrees to go for a paraesophageal hernia repair. So go ahead and walk me through what you're going to do.
Yep, so I'll gain peritoneal access, reduce any stomach or any other organ start within the hiatus that I can safely, and then start with my crural dissection, open the pars flaccida that go towards the right crus, and if I have enough organ to reduce, try to dissect the crura from right to left, going anteriorly first, and then going posteriorly, and then I'll take down the short gastrix of the stomach towards the left crus. By now, I hope to have been circumferentially around the esophagus, put a Penrose in, and then start my mediastinal dissection to confirm intraperitoneal esophagus.
Okay, so you do your mediastinal dissection. You make a hole in the pleura, and his blood pressure drops.
Okay, I will first let anesthesia know that I made a pleurotomy. The first thing I have to do is enlarge the pleurotomy to equalize the pressure between the peritoneal cavity and the capnothorax. I will decrease my insufflation to at least 12 and see if anesthesia is having any hemodynamic changes.
Okay, he drops, they give him some fluids, and they put him on a neo drip, and he comes back up.
Okay, and they should also increase their PREP a little bit to equilibrize the pressure.
Okay, so they're okay with you proceeding. So you do your mediastinal dissection, and there's still like a 2 centimeter nub of the cardia, which is abutting the hiatus. So it does not look like you've gotten a good amount of esophageal length. How high are you going to go on your mediastinal dissection?
My goal is to obtain at least 3 centimeters of 3 to 4 centimeters of intraperitoneal esophagus, without too much tension on pulling it down.
Okay, when you relax on the Penrose, the stomach is still going through the hiatus.
Okay, and I'm already am I closer to the pulmonary vein, pretty high.
You are up to the inferior pulmonary vein on both sides.
Okay, then I think that this person has a foreshortened esophagus from his prolonged tortuous from his hiatal hernia. So he is somebody who I would have to consider a Colles gastroplasty for.
Okay, how are you going to do that?
Let's see. I've only seen that I haven't done one yet, but what I've seen is that you recreate the G junction just further down by stapling the fundus of the stomach. I would have to, I can't really describe it.
Okay, so you perform a wedge gastrectomy up at the cardia to create a neoesophagus or lengthen the esophagus. So now when you let go of the Penrose, the stomach is below, your neoesophagus is within the abdomen. You're looking at a hiatal defect that measures roughly 6 centimeters wide and about 5 centimeters from anterior to posterior. How are you going to close your hiatus?
So that's a very large defect. This is somebody who would benefit from implantation of mesh to reinforce any choreoplasty that I can't perform.
So you put your first posterior choreoplasty stitch in, and you notice that the diaphragm is starting to tear. There's too much tension.
Okay. Then I would not attempt to do any more sutures, and then I would sew in a piece of synthetic mesh.
What type of mesh are you going to use?
I think Phase6 I would use.
Okay.
Next time.
Okay. So I would say very good up until the very end. So number one, I mean, you manage them appropriately, like decompress these people. They're always going to be volvulized when they have these big hernias. The main thing you want to make sure, I mean, he was stable, right? If he's unstable, you should probably get a CT scan to evaluate for any air within the hernia sac, fluid in the hernia sac. You might want to, be a little more urgent if they're unstable because you're concerned about perforation or ischemia. But otherwise, yeah, you stick an NG tube down. Most of these people are going to decompress. They will devolvulize, and you can get them to an outpatient setting. A good number or maybe 5-10% will not. And so then, yes, you need to take them for a repair. I think it's reasonable to attempt a formal repair at that point where you reduce the hernia, you close the crura, you do what you have to do. A bailout would be just gastropexy. So if you can't get the length or the patient is sick or the hole is really big, you can always just do a suture gastropexy or a G-tube gastropexy. It's not ideal, but it's also a safe answer on the boards. If you're gonna mention a callus, you just have to know what you're doing and how to do that. And you just say a wedge gastrectomy up at the cardia, right? It's just kind of a couple staple lines up to create a lengthening of the esophagus. When your hiatus cannot close, you need to do a relaxing incision. All right. And that's it. I doubt they'll ask you to describe every single part of that, but essentially you're incising the right crus between the border of the crus and the IVC. If they ask you to do a left side relaxing incision, you've probably passed the test already because not many people end up actually having to do that. But a relaxing incision allows you to close the crura around the esophagus without tension. The last thing you want to do is put a synthetic mesh around a giant hole in the hiatus because the esophagus is going to lay directly on that and it's going to erode and it's going to be a disaster. So in general, I think using synthetic mesh around the esophagus or the hiatus, I wouldn't say that. That's still a no-no. When you do a relaxing incision, you place your synthetic mesh as a patch on the diaphragm, but that's going to be several centimeters away from the esophagus. So most people, when they do these, you do your relaxing incision, patch it with a synthetic mesh, whatever, Phasix, Synacor, and then you can use an absorbable biosynthetic mesh around the actual hiatus. And so that's typically what I would do. If you get to the point where you don't want to say that on the boards, then you put in a G tube and you suture the stomach to the abdominal wall and you call it a day because this guy came in obstructed. You relieve the obstruction. You can fight the battle of, formally repairing the hernia and the diaphragm at a later time.
Excellent. Well, thank you guys so much for participating in that. Any more suggestions or comments about this case or any of the other cases from the audience? So we should be able to watch the video. This is all being recorded if you'd like to review your performance. But again, thank you all so much for participating and look forward to the next AHS webinar.
Other business things is that we do have a newsletter that you or your trainees are welcome to subscribe to, and that has some sort of hernia stuff. We announce upcoming webinars. We have interviews, and we have some relevant or important or just cool incoming research from past and present. Examinees, please keep an eye out for an email from Margie for a thank you that's going to be coming your way. She's going to need a little bit of information from you to send that. And for an examiners, I really appreciate you being here. We definitely couldn't do this without you. This was a really excellent quality review. Thank you so much.
Thank you.
Thank you, guys.
Have a wonderful night, everyone. Take care.
Bye.